time, I wish to demonstrate several things that are really prolotherapy injection pearls. And we won't be doing a total injection, but we will be demonstrating some of the technique issues that I think can make prolotherapy easier and more effective. The first of these is positioning. It's always important to position the patient very carefully to make sure that they're symmetrical, they're not turned from one side to another, and when we're injecting in the prone position, that they're lying over the pillow so the hips are elevated and the lumbar lordosis is partially eliminated. Another thing is the careful palpation. This needs to be slow and methodical, using our MRIs, my regional investigator, either your thumb or your finger, and we need to be careful not to use the whole hand when we do that, because this confuses the patient about where we're palpating, so they can't tell us accurately where they have discomfort. So the palpation needs to be very slow, with firm, gentle pressure, and asking each point if that point is tender. Marking anatomy is very important, and we need to keep in mind that even if we're expert injectors, carefully palpating and carefully marking anatomy is an important part of our examination techniques. So to demonstrate some of these techniques, we're going to do a small injection. These techniques are applicable anywhere in the body and need to be thought about and followed. First of all, we're going to mark our anatomy. We're looking at the PSIS as we come down around the bottom of the PSIS, remembering that deep tissue pressure coming up under the bottom of the PSIS allows us to feel the bony prominence of the bottom of that bone, coming back along the back edge. So this brings us to our first point, which is, along with careful palpation, deep pressure to do skin depression. This helps getting us more distance on our needle. If we can depress the skin, for example, over the border of the sacrum in this area, we can find that we can get a longer depth with our needle penetration. So we need to find the anatomy and then keep our finger on the anatomy when we insert the needle. In other words, we don't want to feel the anatomy, let it go, and then come out and insert the needle. We want to keep our fingers on the anatomy so that we know that we're in the right spot. We're going to palpate, and we've already palpated this patient. We know that he has some tenderness around the bottom of the PSIS, and we're going to inject 2 or 3 injections in this area to demonstrate some of the different techniques. We're preparing our injection to make a skin wheel with the xylocaine using a 30-gauge needle. We've prepped the skin here with alcohol. When we inject joints, we want to sterilize the skin with whatever product one chooses at this time. But generally, alcohol prep on the skin is adequate for the kinds of injections we're doing. With the needle up, the bevel up on the needle, we come in just intradermally, and you can see the skin wheel raised right there. It has to look like a PPD, the tuberculin skin test, where the skin wheel is actually raised. This is adequate numbing that allows us to place the needle through the skin without discomfort. And interestingly enough, this often makes it so the patient does not feel the pain of the injection deeper in. I think probably by eliminating the firing of the A pain fibers in the skin itself, we probably dampen down the firing of the deep C pain fibers, so people feel more of a pressure sensation rather than a pain sensation. We're now going to, again, press on the area to feel the anatomy, where my fingers are locked on the bottom of the PSIS. We want to maintain a perpendicular position to the bone, and this requires one to have that sense in your mind of what the bone looks like underneath your fingers and underneath the needle. And then when you're doing your injections, you want to be close down to your work. You don't want to be far away but you want to be close to your work so that you're actually in the field. And we enter the skin through the skin wheel and slide our needle in gently and slowly until we feel the bone. We can feel the needle tap on the bone. It's not necessary at this point to jam the needle in the bone, but we can go gently and easily to find that spot. And we recommend gentle, easy injections coming down on the bone, and once we've tapped on the bone, doing our injection at that point. We can inject in several ways. One is to hold the syringe like this and inject, but we often find that people will get tired thumbs or thumb pain and need their own thumbs injected with prolotherapy solution when this happens. So we often recommend injecting in this position. You're unable to watch how much solution you're injecting very well, but you get used to that. It's an automatic process to inject a half cc or 1 cc into an area. And so we tap on the bone and just inject 1/2 to 1 cc at that spot. If we have trouble injecting, putting the solution in, we can withdraw the needle just a millimeter or so it's not in the periosteum, and then we can inject. Now at this point we have 3 choices. We can take the needle out and re-enter the skin at another position. And that's legitimate, and when I recommend this when you're beginning to learn injection therapy, to do individual injections so that you understand the orientation of your needle. A second choice is to bring the needle out to the skin line so it's out of the fascia. So I've withdrawn the needle and I can feel it now that it moves freely in the skin, underneath the skin. Sometimes you'll feel it actually pop out of the fascia, and there it actually popped out of the fascia, and you know you're just below the skin line. When we move the needle now, the needle shouldn't bend, it should stay straight. And this is another principle when you're injecting, to keep the needle straight like it's a straight projection of the syringe. We can now reorient the needle, aiming a little bit more cranially in this case, and go back in with our needle, hit the bone again, and re-inject. We can now come back out to the skin line. We need to be out of the fascia, because if we're still in that fascia and we redirect the needle's going to go down in the same hole again. We're now redirecting caudally, and we're going back in and hitting the bone, and we're going to re-inject solution. So we've done now 3 injections through 1 hole with this particular reorientation technique. Now the thing to remember about this technique is that we're in this far with the needle. And so if we look at the projection of this, and we come straight in like this, and then we come back out to the skin line, and we move our needle in this direction and go back in, the tip of the needle is actually going to move further away than the base of the needle, the further in we go. You can see that here the tip is very close to the midline, but if we've angled it this much and we go in like this, by the time we get down to this depth, the needle is quite far from the midline. So in other words, if we're in this plane and we come straight in, then we come back out to the skin level, and then we tip the needle, and this is about 15 degrees. We go in a little ways, we're still very close to the midline, but if we go in a ways like this, then the needle is off the midline by a much longer direction. And so our injections are actually further away from our injection site than we might imagine. So it's important to keep that orientation when you're doing these injections. We now have gone through 2 possibilities in terms of techniques. One is taking the needle out of the skin and then just doing another injection nearby. And again, for beginning prolotherapists, this is the technique I recommend so that you maintain your orientation to the bone and you know exactly where the tip of that needle is all the time. The second technique is to come out to the skin level, redirect the needle, go back in through the same hole, come back out to the skin level, redirect the needle, and go back in again. The third technique is called skin sliding. And with this technique, we're going to enter the skin, do an injection, then come back out to the skin level, out of the fascia again, so that the needle slides freely, and then we're going to slide the skin. This works particularly well in areas where there's loose skin, like you can see here over the bottom of the PSIS. With this technique, one needs to be aware that you are injecting multiple sites, and then when you remove the needle finally, the skin pops back to the original site, and you may lose track of where you've injected. So I tend to think of this as injecting in boxes, so that I do 4 corners of a quadrant, then come out with my needle and remember then that I've done the 4 corners of the quadrant. We'll demonstrate that technique now. We come in again directly and we hit bone. We do 1 injection here and come back out to the skin level. We're out of the fascia. We can see the needle slide freely now as it moves across. And so we're going to slide this direction and go back in and do another injection. And now we're going to come back out with our needle and slide down. And we can see that we're down well below the PSIS now. Go back in, we hit bone at a little deeper level, and then come back out, slide laterally, redirect our needle a little bit medially. We hit bone again at a little deeper level, come back out again, slide up, and again directing our needle in, hit bone, and do a 4th or 5th injection by this time. And we can see that we've moved the skin around a ways. We're going to pull the needle out now, keeping the needle in this spot, and the skin drifts back. We can see that we've injected here, 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 and over here with this skin sliding technique. Now the problem with this is that unless I have a good mental image of that in box that I've injected or area that I've injected like that, I may think, oh, I need to come right here with my needle, when in actuality I've already done an injection there and I really need to come on up around the corner here. When one is injecting, it's very important to imagine the needle tip as being a projection of your mind's eye. And that is having a sense of how deep the bone is, so that you're gauging the depth of your injection. If you think that you've gone deeply enough to hit the bone and you haven't hit it, then you may wish to reposition your needle or redirect your needle, because you may be sliding off into an area where there is no bone. And it's perfectly safe to do that a number of times, but again, getting that experience of how deep the bone might be is a good way to proceed with this. In thinking about gauging depth, once you've found the depth, you've hit the bone in a particular area, you know that's the depth, and you can picture how deep that is on your needle, and you don't want to go poking deeper than that. You might wish to reorient your needle instead. As you're injecting, feel what's happening with the needle. Ligaments have a gritty feel to them, so that texture as you get near the bone in the ligament is an important one to notice. So the sensitivity of your injecting hand here and what you're feeling is extremely important, in addition to your palpating hand. In many areas, the perceived edge versus the real edge is a challenge. For example, over the sacrum, when we palpate, I feel that the edge is here, and that's my perception of where the edge is. But there's probably this much tissue between me and the sacrum. So the actual edge may be further over than I imagine. But it's fair game to go ahead and aim for the perceived edge, but if you don't hit it at the depth you think you should, then move over. Redirect your needle and go back in to see if you can hit the real edge versus the perceived edge. This is true on the ilium, it's true on the lateral border of the sacrum, and it's true in many areas of the spine as well.